Warm greetings from Manipal. Myself, Dr. Chandrika Nayak, Professor of Biochemistry at Manipal Academy of Higher Education. I am here to present a few biochemical points about the topic vitamin B12 or cobalamin. Let's begin the discussion on this with few case scenarios. Let's begin with the first case. It's a 55-year-old lady presenting to the medicine OPD. What is her complaints? It's a tingling sensation, numbness of the hand and feet. She has also developed some sort of vibratory and position sense. There's a spastic gait disturbance. She is highly irritable. Blood investigations reveal megaloblastic anemia. This is to be noted. Not only that, urine findings suggest there is increased levels of methyl malonic acid and homocysteine. So, important key take points will be megaloblastic anemia, tingling sensation in hands and feet and urinary findings. Let's move to the second case. It's Betty, a 75-year-old woman. Similar complaints, numbness, tingling in her legs. But after losing her husband, there is more information in this case. That is, she is staying alone, she is malnourished. She has a bad diet history. She is not on any vitamin supplements. Laboratory results are again revealing the same findings. There is increased methyl malonic acid in the urine and the physician is now suspecting a vitamin deficiency. Case 3. It's a 6-month-old baby admitted to the hospital, pale, flaccid, non-responsive to pain stimuli. Mother is a strict vegan. Point to be noted here. Child is exclusively fed on breast milk and investigation is pointing out similar findings. What is it? It's the peripheral blood smear showing large immature RBCs. So, with these three cases, of course, the child's urine findings again similar to the previous two cases, rise in methyl malonic acid and homocysteine levels. So, all the three cases are pinpointing at similar clinical findings, similar urine findings. So, let's explore the topic. So, what will be the likely questions that are arising in your mind after listening to these three clinical case scenario? What's the diagnosis? What's the micronutrient the physician was suspecting to be deficient? What are the functions of this micronutrient? Is it a vitamin? Is it a mineral? And what is the biochemical basis for all the clinical findings that were explained in the cases, all the three cases? And what's the reason for the urinary findings? So, it's time to explore this topic and the learning goals for understanding this case. We have to know which is the deficient mineral. It's none other than vitamin B12, commonly referred to as cobalamin. So, what are the learning goals? Let's begin with the metabolism of vitamin B12. Let's explore the structure, move to the sources, the requirement or the RDA. How is it absorbed? How is it transported? How is it stored in the blood? What are its coenzyme forms? What are its biochemical functions? What are the deficiency disorders? We have to study about deficiency symptoms. We have been seeing in the case megaloblastic anemia. So, we need to know why megaloblastic anemia, why neurological manifestations in this case, and of course, finally, we will wrap up the topic with some recap questions. Cobalamin. Initially, people used to refer it as the extrinsic factor of Castle. Some used to refer it to as anti-pernicious anemia factor. So, I think as we progress to this topic in this lecture, you will get the answer why was it called extrinsic factor and why was it called anti-pernicious anemia factor. Yes, let's begin with cobalamin, the water soluble vitamin. All of you are aware there are two groups of vitamins, the water soluble ones and the fat soluble ones, and this belongs to the water soluble vitamin. You can also call it as vitamin B12. It can be stored in the liver. We usually make a general statement, water soluble vitamins are not stored in the body, but the exception is cobalamin. It is stored in the liver. And how much? It can be stored in the liver up to 2 to 5 milligram. That's the reason even if you don't take vitamin B12 for some time, symptoms won't arise because there's enough stores in the liver. So, for the deficiency symptoms to manifest, it will take some time if you have gone devoid of vitamin B12 for months. Manifestations have to be studied. You should remember that it will take some time for the symptoms to arise, as I told you, because it is a water soluble vitamin that's stored in the liver. It's called a hemopoietic vitamin. What do you mean by this? Any vitamin that has a role in erythropoiesis or RBC formation, maybe in heme formation, maybe in hemoglobin formation, or maybe in RBC maturation. Any one of these factors, if it is involved, we call this as a hemopoietic vitamin. Cobalamin is a hemopoietic vitamin. Let's explore the structure first, and then maybe we will understand why is it called cobalamin. So, let's begin deciphering the structure. It has a Corin ring structure with a cobalt atom in the center. So, if you look at the picture, in the picture there is this red ring I have put around the cobalt atom. Since it has the cobalt atom in the middle attached to the nitrogen atoms of the pyrrole rings, we call it as the Corin ring structure. Cobalt, as you know, has 6 valencies. If you see the structure here, you can see that cobalt is forming coordinate bonds with 4 nitrogens of the 4 pyrrole rings. So, 4 valencies are satisfied. The fifth one, as you can see, is attached to a benzimidazole ring. So, you can see this is a substituted benzimidazole ring. So, that is the 5th bond, and that is why the name cobalamin, cobalt and this group. Now, what is the 6th bond attached to? The 6th bond or the 6th valency is satisfied by any group. If you look at the picture here, can you see an R group written here? And this R group means it can be bound to a methyl group. You can call it methyl cobalamin. It can be attached to deoxyadenosyl group. You can call it deoxyadenosyl cobalamin. It can be attached to cyanide. It's called cyanocobalamin group. Please note that whatever commercial B12 that we consume is called as the cyanocobalamin because the commercial preparation has the R group has the cyanide. So, that is why it is called as cyanocobalamin. So, that was about the structure of methyl cobalamin or deoxyadenosyl cobalamin or the general structure of cobalamin. Moving on to the sources of vitamin B12. Now, this has to be kept in mind. What is the most important thing you should remember? There are no plant sources. If you want vitamin B12, you have to rely on non-vegetarian sources. Of course, there is the microflora in the gut that can contribute little bit, but please remember there is no vegetarian source. So, if you are a strict vegan, not even consuming milk or milk products, then you are at a high risk of developing B12 deficiency. Of course, the picture is showing you some non-vegetarian sources which are very good sources for cobalamin. I stress upon this point, the second point I am projecting here, that is it can be synthesized by microbes. In the gut we have the microbiota, they can produce B12 and they can be the source of B12 for us. Of course, if you want to be risk free and have good vitamin B12 levels, it is better to consume non-vegetarian sources, liver, eggs, fish, red meat. But if you are a vegetarian, I think you should not fall back on consuming milk or milk products. So, for vegetarians, it is milk or milk products, and for non-vegetarians, they are on the safer side. What do you mean by RDA? All of us know that, isn't it? Required, recommended dietary allowance. How much should I eat every day? So, what is the RDA for cobalamin? Males and females roughly 2 micrograms. I am referring to the adult population. Pregnant women, of course, the demand is more. There is a fetus growing inside, 2.2 micrograms per day, and if it's lactation, again you are feeding the child, so the milk has to be enriched with B12. So, a lactating woman should consume somewhere around 2.6 micrograms of cobalamin. This is a very important concept, absorption of dietary cobalamin. Usually water soluble vitamins do not need any proteins to be attached and then transported, but again cobalamin is an exception. It is always bound to a protein. They say that even in the dietary sources, B12 is always attached to a protein and then it is transported. So, where does the absorption start? So, before the absorption, there are many steps happening in the stomach, the duodenum, and then finally absorption is taking place in the ileum. So, I repeat, a lot of preparation needs to be done. Absorption is in the ileum, but preparation starts from the stomach, moves through the duodenum, some more changes, and finally absorption in the ileum. So, we are now concentrating on the stomach. You can see a picture of stomach here, and a person has consumed dietary B12. I am again reiterating, B12 is always bound to a protein and it's now come through the mouth, through the esophagus into the stomach. As it is moving down the esophagus, it's mixed with the salivary juice. The salivary juice has an important factor. You can call it hepatocorrin or you can call it R factor. Now, the food is mixed, the B12 is along with this R factor, it is moving down into the stomach. Just a while ago, I told you even dietary B12 is come bound to the protein. What happens in the stomach? There are proteolytic enzymes like pepsin. Now, pepsin will start acting on that protein which is found in the dietary combination with the B12. It will degrade it. B12 becomes free, and that is why in the stomach, in the correct pH, B12 binds to the R factor. So, you can see the picture here. Now, the R factor released by the salivary gland is bound to the B12 of the diet. So, this combination R with B12 is happening in the stomach and it is not undergoing any change. It easily passes out down to the duodenum. So, rest of the changes in the duodenum. What happens in the stomach? Please remember, dietary protein which was attached to the B12 is released by the pepsin action. Free B12 binds to R factor. The R factor B12 combination is formed and is moving down slowly to the duodenum. Another important factor that is very important to be noted, that is, you can see here there are the parietal cells which will secrete the hydrochloric acid, and along with it, it releases an important factor which is called the intrinsic factor of Castle. So, the intrinsic factor is very much needed for B12 absorption, but if you look at this picture, it has no role. It is simply moving down along with the food into the duodenum. So, till the duodenum, intrinsic factor has no role. When I started cobalamin, I told you earlier people used to call it extrinsic factor of B12. Why? Because this extrinsic factor of Castle or B12 is going to join the intrinsic factor in the duodenum. That is why the name. And anti-pernicious anemia factor, I will explain it a little bit later. Fine. So, right now we have the combination of the R protein and the cobalamin of B12 attached to each other in the stomach moving down to the duodenum. So, it is time to understand the changes in the small intestine. First, we will understand the changes in the duodenum, followed by jejunum and absorption at the ileum. So, you can see the picture here in the animation. You can see the R factor and B12 have now arrived as a complex into the duodenum. What happens in the duodenum? There are pancreatic enzymes or proteases coming along with the pancreatic juice. What do the proteases do? You look at the picture, you will understand. The proteases will digest this R factor, it will chop off the R factor and free the B12. And I was repeatedly telling you, intrinsic factor released by the parietal cell in the gastric juice has now come into the duodenum along with the food, and now is the time when our B12 and the intrinsic factor join together. The extrinsic factor and the intrinsic factor are now joining and forming a complex that will help in the absorption of cobalamin. So, if you can see here, duodenum is the time or the place where both have been forming a complex. It moves through the jejunum, no significant changes in the jejunum. What happens is the important absorption step in the ileum. So, if you see here at the ileum, on the intestinal mucosal cell, there is a protein or a transporter called cubilin. Now, this cubilin is a transporter protein which can easily attach to the intrinsic factor B12 complex. And what happens once they bind to cubilin is it will allow the B12 to permeate into the mucosal cell. So, you can see in this picture now the B12 has come into the intestinal mucosal cell, and from here it will be transported to the blood. So, you can see here that the B12 has now come into the blood. So, it is in the blood, immediately it should bind to a protein which is circulating in the blood. Name of the protein, transcobalamin 2. So, please remember, cobalamin of B12 always needs a protein to cling to. Initially in the diet it was with some protein, then inside the stomach it started attaching to R factor, in the duodenum to intrinsic factor, and finally for absorption you need intrinsic factor B12 combination, of course you need cubilin 2. Okay? And once it has come into the blood, it will need transcobalamin 2. So, these were the stages of absorption of vitamin B12. Where does absorption takes place? Ileum. What are the important factors it needs for the absorption? That is R factor initially, then intrinsic factor. We also understood the reason why B12 was initially called by scientists as extrinsic factor of Castle. Clear? So, I think we should move ahead to the functions of vitamin B12. If we study the function, we can explain why if there is deficiency there is anemia, why if there is deficiency there is neurological manifestations. Clear? So, under functions you should know B12 has two important coenzyme forms. The first one is called methylcobalamin and the second one is called deoxyadenosylcobalamin. So, these are the two coenzyme forms and they are needed for some important biochemical reactions, and with that biochemical reactions it does its function. So, let us begin with the first one. What is the role of methylcobalamin? Methylcobalamin is a coenzyme for an important enzyme. Which is that enzyme? It is methionine synthase or homocysteine methyltransferase. So, let us study the role of methylcobalamin in generating methionine. So, let us see this reaction. Methionine synthesis from what? From homocysteine. So, homocysteine should be converted to methionine. What is the enzyme that you need? Methionine synthase. You can also call it homocysteine methyltransferase. It simply means you need a methylation reaction. So, who is the donor? Methyl donor. It is our cobalamin. So, look at the picture now. The methyl donor is methylcobalamin. So, methyl group is donated by methylcobalamin. After it donates the methyl group, it is converted to cobalamin. Now, for this reaction to continue continuously, you need regeneration of cobalamin to methylcobalamin. For this, you need tetrahydrofolate or folic acid. So, folic acid and B12 are usually having functions hand in hand in this reaction. So, if you see here, regeneration of cobalamin to methylcobalamin happens when methyl is donated by N5-methyl tetrahydrofolate, that is converted to tetrahydrofolate. So, this reaction you have to remember for two reasons. One, methionine synthesis. Second, for the regeneration of cobalamin to methylcobalamin, you will need N5-methyl tetrahydrofolate, and please remember, this is the only reaction in the body to convert N5-methyl tetrahydrofolate to folic acid. So, this was the function of the first coenzyme form, and the first coenzyme form was methylcobalamin. The second coenzyme form or the second function of cobalamin is 5'-deoxyadenosylcobalamin cobalamin. So, deoxyadenosylcobalamin is a coenzyme for L-methylmalonate CoA mutase. It is involved in the metabolism of fatty acids which have odd number of carbon atoms. When there are odd number of carbon atoms in a fatty acid, it undergoes beta oxidation. We know that beta oxidation, what is the common product? Acetyl-CoA. But if it is odd numbered, there is generation of propionyl-CoA. Now, this propionyl-CoA is converted to methylmalonyl-CoA, and the methylmalonyl-CoA is metabolized further. So, for the reaction of conversion of methylmalonyl-CoA to succinyl-CoA, you need this enzyme methylmalonyl-CoA mutase. And what is the coenzyme? You can see the coenzyme, it is 5'-deoxyadenosylcobalamin. So, for the metabolism of fatty acids with odd number of carbon atoms, you will need cobalamin. Let us move on to cobalamin deficiency. Before we study the deficiency symptoms, I think we need to study what could be the cause for deficiency. Nutrition, diet, we just spoke. Vegetarians will be at risk, non-vegetarians safer side. Yes, right? So, let us delve deep into causes for cobalamin deficiency. Let us begin with nutritional. We have already discussed, but again let us recall that. Dietary deficiency is rare, but it can occur in vegans who even avoid consuming milk. Gastric causes. We saw the importance of intrinsic factor for the absorption of B12. So, if a person is having problems with secretion of intrinsic factor, he will not secrete intrinsic factor, and therefore there will not be B12 absorption. Such a type of anemia is called as pernicious anemia. I repeat, if there is deficiency of intrinsic factor, there will be deficiency of B12 because there is no absorption, and B12 deficiency causes anemia, and that anemia is called pernicious anemia. And some people, due to gastric cancers or some other reasons, will have the part of the stomach removed. We call it gastrectomy, and in gastrectomy patients what happens? There will be removal of the parietal cells, no intrinsic factor, so they too can develop pernicious anemia. What are the intestinal causes? For the safe absorption of vitamin B12, we need a very good ileum. So, if there are defects in the ileum, like you can see there is Crohn's disease or the stagnant loop syndrome, these are the reasons why the absorption in the ileum will be affected. So, I repeat, causes can be threefold. The first one, nutritional. Second one, gastric causes. Third one, intestinal causes. With these three causes, let us move ahead to understand the deficiency symptoms and the biochemical basis for that. What are the features? Hematologic, changes in the blood. If you take peripheral blood smear, you will see the RBCs quite big. We call it macrocytic anemia or megaloblastic anemia. Neurologic, a lot of neurologic symptoms will come up. That is, you can see here we have listed, there is neural degeneration, demyelination can occur, degeneration in the spinal cord also can be seen, and there will be the other neurological symptoms, and some of them we had listed in the first three cases, right? Tingling sensation, numbness, changes in the gait, all these are due to B12 deficiency. We call it as the neurological manifestations, and of course the urine findings. If you take the urine sample of such a person with these complaints, definitely you will see a rise in the level of homocysteine and methylmalonic acid. Both are not normal constituents. If they come in the urine, it is an indicator that the person is having B12 deficiency. Now is the time to understand the biochemical basis for each. Before I explain macrocytic or megaloblastic anemia, I think we should little bit try to recall the different types of anemia. Anemia can be macrocytic anemia. What does this mean? The RBC size is going to increase. The hemoglobin production is normal here, so the cell is growing quite big, but the division is affected. When can this happen? Either if there is folate deficiency or if there is a deficiency of B12. There is something called as microcytic anemia. The RBC cell starts appearing very small, and what is the reason? There is some problem in heme synthesis or hemoglobin synthesis, and that can happen if there is iron deficiency, vitamin C deficiency or pyridoxine deficiency. So, that is microcytic anemia. This hemolytic anemia, this is totally different, nothing due to vitamins or anything. It is because the RBCs are breaking down at a very fast rate. Okay, that can happen due to J6PD deficiency, sickle cell anemia and many more causes. And pernicious anemia, I told you when I was explaining the absorption in the stomach, right? You need intrinsic factor. So, if there is no intrinsic factor, there is deficiency of B12. If there is deficiency of B12, there will be megaloblastic anemia like picture, and this type of anemia is called pernicious anemia. So, let us move ahead with understanding the biochemical basis. The first manifestation, the hematologic manifestation. Why do we see anemia in cobalamin deficiency? This is explained with folate trap hypothesis. Folate trap hypothesis is explained perfectly with the help of this reaction. Just a while ago we saw this reaction, right? What do you mean by folate trap? See, in this case, if you see here, I just showed you this. If there is a deficiency of cobalamin, what happens is this reaction will not take place. N5-methyl tetrahydrofolate will not be converted to folic acid. What is the meaning of this? That means folate is going to trap in the body as N5-methyl tetrahydrofolate. All the folic acid will stay there as N5-methyl form. You will not have free tetrahydrofolate or any other forms of tetrahydrofolate. So, that will affect our cell division because folic acid is needed for cell division. So, I slowly repeat it for you once again. If there is B12 deficiency, all folate is going to be trapped as N5-methyl tetrahydrofolate because this reaction is not going to happen. So, you can see here there will be a deficiency of tetrahydrofolate. If there is deficiency of tetrahydrofolate, no other coenzyme forms of tetrahydrofolate. So, tetrahydrofolate or folic acid is needed for DNA synthesis. DNA synthesis, cell division falls. Cell division will be affecting those in the bone marrow or the intestinal mucosal cells. These are the two places where cell division is rapid and happening throughout the lifetime. So, what happens is it affects the bone marrow cell division, erythropoiesis, and so what happens is there will be megaloblastic anemia. The RBC grows on in size because hemoglobin production will be fine, the size goes on increasing, but the cell is not able to divide. So, the blasts are coming and you can see it as megaloblastic anemia. So, if there is B12 deficiency, you can expect folate trap, and due to folate trap, megaloblastic anemia. Let us explain the second one, that is the neurological manifestation, the biochemical basis. I already told you there is a coenzyme form of cobalamin called deoxyadenosyl cobalamin. So, if there is no deoxyadenosyl cobalamin during deficiency, what happens? Odd carbon number fatty acids will be converted to propionyl CoA, then propionyl CoA carboxylase converts it to L-methylmalonyl CoA and it will be converted to succinyl CoA. This is the normal course of metabolism, right? But now what is happening? If you look at the picture, there is cobalamin deficiency. So, you see here there is cobalamin deficiency or B12 deficiency. So, this reaction will not happen. So, if this reaction does not happen, there is a build-up in propionyl CoA because there is a backflow. Propionyl CoA is not able to be metabolized further, and propionyl CoA, if it builds up, it creates some damage. What is that? It leads to synthesis of some abnormal fatty acids. Okay. So, you can see there is increased synthesis of certain abnormal fatty acids, and that gets incorporated in the cell membranes or chiefly in the central nervous system, in the myelin sheath, and that is the major reason why these people with B12 deficiency develop neurological manifestation. If you recall, in the case we were saying the lady was complaining of tingling, numbness, unsteady gait and so many neurological complications. That's because of this reaction. In this reaction, if this doesn't happen during B12 deficiency, what you end up with is neurological manifestation. So, we explained the biochemical basis for anemia, that's megaloblastic anemia, and we explained the basis for neurological manifestations. Why homocystinuria? Why methylmalonic aciduria? Again the same two reactions we are going to repeat. Let's repeat it for the benefit of you. That is, these are the two reactions we know needed by the both of them are requiring B12 coenzymes. Okay. Now there is B12 deficiency. These two reactions will not happen. So the substrate is going to build up. So look at the picture now. The substrate homocysteine and methylmalonic CoA both are building up. Both are water soluble. They will appear in the urine, and as you can see in this picture here, it is homocystinuria and methylmalonic aciduria. Why? Because there is a buildup of homocysteine, buildup of methylmalonyl CoA, water soluble, they come in the urine. So, in these patients who are having B12 deficiency, if you just take their urine sample and send it to the lab, definitely there is homocystinuria and methylmalonic aciduria. So, it is confirmatory test for the physician to treat B12 deficiency. So, what are the investigations? A physician can check the serum cobalamin levels, he can check the serum homocysteine levels, urine homocysteine levels, serum methylmalonate levels, Schilling test is also there, and a simple peripheral blood smear. Look at the picture here, peripheral blood smear, look at the RBC size, it has gone big, it is called megaloblastic anemia. This confirms that the patient who is complaining of all these cases, whatever we saw complaints, that is due to B12 deficiency. So, back to the clinical scenario where we started with. Let us take up only one case. We spoke about the 55-year-old lady. What was the complaint? I have highlighted it in red now. She complains of tingling sensation, numbness in the hand and feet, neurological manifestation, and then she is complaining about gait because the CNS membranes and all have been incorporated with abnormal fatty acids, lots of neurological complications because of that, and even the gait is affected, highly irritable. And if you look at the peripheral blood smear of this lady, definitely I will tell you it is megaloblastic anemia, and that is what we saw in a picture just a while ago, right? Yes. And urine, if you take her urine sample and test it in the biochem lab, definitely there is methylmalonic aciduria and homocystinuria. So, with this I think we should be able to get a clear picture of cobalamin, its functions, its deficiency, manifestations and the biochemical reasons behind the clinical case. So, let us revise the topic with one or two MCQs. The first MCQ for you. Deficiency of vitamin B12 leads to following types of anemia. I told you there are different types. Microcytic anemia, macrocytic or megaloblastic anemia, hemolytic anemia. Which one will you choose? Repeatedly I have been telling you RBC size is increasing. What is the answer? That is macrocytic anemia or megaloblastic anemia. Second question. Which among the following macromineral is a component of B12? What did I tell you the name of B12? I told cobalamin. The answer is hidden in the name, cobalamin. So, which one is the micromineral? Is it iron, copper, cobalt, magnesium? Cobalamin, clue is already there. So, the micromineral is cobalt in the structure of cobalamin. Last question before we wind up. Which among the following protein transports cobalamin in the blood? It is transporting cobalamin. So, do you get a hint? Is it intrinsic factor? No, that was absorption. Was it haptocorin? No. It was for transport in the stomach as R factor. Was it cubilin? No, that is for absorption at ileum. So, which one is for transport in the blood? Transcobalamin. Transporter of cobalamin, transcobalamin 2. So, that is about the B12 topic. I hope you have understood the clinical case. You have understood how B12 deficiency patients will present at the medicine OPD, and what are the tests that you can do, what are the investigations that you can do to confirm B12 deficiency, and then put the patient on B12 supplements. Thank you very much.